second session of the day. And I'm sure on day-to-day practice, number of the patients will come to you with a diagnosis of the pancreatic cyst. Thanks to availability of good quality triple phase CTs, excellent quality, the 3T MRI, and good training by the radiologists, it is not uncommon to have incidentally detected asymptomatic pancreatic cysts. Are they of any relevance? Do they need follow-up, or how do we go about managing them? For the session to be presented, we have Dr. Sundeep Laktakia, who is a well-known figure in field of endosonography in India. He is incidentally also the Secretary General of Society of GI Endoscopy of India. The session will be moderated by Dr. Malay Sharma, who all of you know is one of the pioneers and the doyen of endoscopic ultrasonography in India. So may I request Dr. Sundeep Laktakia to start his presentation, please.
Good evening, sir. Good evening, friends, and it's an honor and pleasure to be here. Thank you, Dr. Arora, for inviting me for this wonderful clinics in Hepato-Biliary diseases. Am I audible?
Yeah, we can hear you well.
Okay. Can you see my slide?
You have not shared yet. You can see your face.
Okay. How to share my share here?
Are you on the Zoom mode?
Yes, I am on the Zoom.
Yeah, right in the center, there is a yellow icon with the arrow up called share your screen. Yeah, we can see it. Yes.
Okay. Thank you very much. So, pancreatic cyst advances in management, that's the topic which has been allotted. And when we read about this and face this in a day-to-day practice, they are a very common problem, but each patient is an individual on his own, and we are not sure which way to follow. To sum it up, actually, if I say pancreatic cyst, how to manage, it's really confusing if you see the literature. Having said that, I'll try to decrease the confusion as we come to the talk, and then we can have discussion, and we'll know in the end whether we have actually improved our knowledge or we are still confused. I'll be covering these aspects: the diagnosis, guidelines, surveillance, and surgery. As Dr. Arora had rightly said, these pancreatic cystic lesions are high in prevalence in asymptomatic patients and seen in about 2.4 to 13.5%. So there are a substantial chunk of normal people who go for imaging for some other reason and they are found with this lesion. And then they get referred to one of us, and then we have to dissect it out and how to take it forward. These cysts increase with age. So as the population is higher, age-wise, these cysts are detected more. For example, you see patients who are more than 70% who go MRI for some other reason, neurological disorder or age-related issues, about 2 out of 5 will have an incidental pancreatic cyst. But still, if you find that most of the cysts are less than 2 centimeter in size, and that's a good part of it because they do not cause too much of a problem. Cysts which are more than 2 are uncommonly found. Since we have a wide variety of audience in this group, including PGs, there are various types of pancreatic cysts that are classified according to their nature. Pseudocysts being the commonest, serous cystic neoplasm, mucinous cystic neoplasm, IPMN, pseudopapillary epithelial neoplasm. Even neuroendocrine tumors can have cystic degeneration and others. Of these, the most common is a site IPMN literature. The mucinous, IPMN, SPEN, and cystic PNET have a malignant potential. When we say mucin producing tumors, we basically include mucinous cystic neoplasm and IPMN. SPEN are much more seen, commoner in younger age patients, especially females, and often those cysts which are communicating with the main pancreatic duct are either pseudocyst or IPMN, and they have high amylase in that fluid. So these are the kind of patients that you will see sometimes when they are referred to you. For example, on this image, you see a large cystic lesion in the head with central calcification. Another one on the right side has multiple small cysts all around, but very large in size. And if you do another imaging, if the first imaging is not classical, then you find other features. For example, this is microcystic, very classical of serious cystic neoplasm. On the right panel, you see a cyst with variable size, large and small, with a central calcification. These are classical images to suggest the diagnosis is established by imaging itself. For mucinous cystic neoplasm, another common one, you have large cyst, but the peripheries will be calcified and there will be no communication with pancreatic duct on imaging. These are the EUS images. I just want to highlight these videos and CTs and other images to audience so that they get sensitized to what is classical and what when we say is non-classical. So the left one has a thickened wall with some septa inside. On the right panel is another lesion which will just appear. This is the pancreas. It's on the posterior part of the pancreas with very thick septa inside. The next common one is IPMN, and there are basically two varieties, the main duct and the side branch, and a combination of two is called the mixed variety. The main duct, as the name suggests, the main pancreatic duct gets dilated either segmental or entire extent. And if it's in entire extent, it is dilated, you'll have mucin projecting from the papilla, which can be from the main papilla or from the minor papilla or both, or sometimes even fistulae are created between the pancreatic duct and the GI tract, which is stomach, duodenum, proximal duodenum, or distal duodenum. Side branch IPMN, as the name suggests, arise from the side branches of the main pancreatic duct and they appear like grapes. They are cysts which are located side by side with intervening normal parenchyma. For example, if you see it here, this is a patient who has a small cystic lesion in the head, which is communicating with the main pancreatic duct here. This is a very small lesion. Whereas on the right panel, you can see a patient who has a dilated pancreatic duct. This is a radial EUS, which is hugely dilated, but many hypoechoic lesions within the dilated duct. And these are the mural nodules within the duct. If you compare the MRCP and CT, MRCP and ERCP, these are the appearances. They can have segmental duct dilatation with filling defects, which can sometimes mimic chronic pancreatitis stone. And that's why it has to be differentiated in areas which are endemic like India, or they can be a side branch IPN or a combination of two. Having said all these things, this table tells you that these various lesions on the left panel have certain characteristics which are classical, age-wise, appearance-wise on imaging, and their molecular characteristics. All of them require surgery except serous cystic neoplasm, which has a very low possibility of any malignancy. The rest have variable degree of malignant potential, varying from 20% in MCN and pseudopapillary tumor to 60% in the main pancreatic duct tumor and branch duct about 25%. So do all patients who present with this should undergo surgery? Because that prevents their ultimate improvement. If not, how do we follow them? And that's the part of this talk. Now this slide tells you a lot of things. From 2005 onwards, there are many guidelines coming from various parts of the world. The ACG Guidelines 2005, the Sendai Guidelines 2006, then we have Fukuoka Guidelines in 2012, 17 and 18, and WGO classification in 2019. When you have so many classifications or guidelines coming up in a short period of time of a decade, it tells that things are not very clear. Nobody really knows what is to be done. And that's the sad part of it. We have a reasonable amount of literature. All the quality of studies are not perfect. And that's why this difference of opinion between the various guidelines. So the common 5 guidelines in last 5 years are AGA guidelines, which publish in reputed Journal of Gastroenterology, the IAP guidelines in Pancreatology, the American College of Radiology in JACR, American College of Gastroenterology in AJG, and European guidelines in gut. So good association, reputed association in reputed journals, but still the final answer for a reader to make an objective interpretation is still difficult. And why is it so? Because the quality of evidence which is used by all these guidelines on which recommendations are made are poor. So if we have a randomized control trial, that's a very good evidence, but most of these studies are retrospective, observer dependent. Having said that, there are some differences also in the different guidelines. The Fukuoka guidelines, which has been modified in 2017, only addresses to IPMN. But it says broadly as the mucinous cystic neoplasm, but it's mainly limited to IPMN. The ACG guidelines cover most of the cystic neoplasm, but they include cysts which are related to the genetic aspects. People who have genetic predisposition to cystic neoplasms and malignancies were excluded in these guidelines. European guidelines are a very broad guidelines which take all cysts put together. And if you see this Venn diagram or circle in circle, majority of the cysts are asymptomatic and 1/3 or even lesser are symptomatic, which AJ guidelines take all of them. Also, the European and the Fukuoka guidelines recommend all patients who have symptoms because of the cystic neoplasms, that is either jaundice or pancreatitis, should straight away go for surgery without further investigations. Whereas American College suggests that they should also undergo subsequent EUS and FNA and then have a multidisciplinary group discussion to decide about surgery. So these are finer nuances and which you can use depending on what is available to you and how you interpret these guidelines. For example, this ACG guidelines is quite practical, but if you see the flow chart, it's very confusing. And there's no point spending more time over here in this forum. I'm sure people can read these guidelines and how they follow. So the basic premise of all these guidelines is when and how to assess the risk of pancreatic cystic neoplasms. If the cyst is symptomatic, most are not. In fact, patients start imagining symptoms once they are diagnosed with it, and that's why a good history taking becomes an important issue. But if they come with symptoms and you find this cyst, then they are actually important. Symptom meaning if they have recent jaundice or a pancreatitis which has happened and it is linked to the cyst that they have. In such situation, you can do an EUS with FNA, or you can directly consider a surgical evaluation. But most often the cysts are of this category where they're incidentally found and they often have low risk features. I'll come to this later. And these are the ones which can be either subjected to non-invasive surveillance. As the term says, non-invasive means imaging, which can be in the form of MRI, which is most preferred by most societies. Or it can also be discussed with the patient because everybody has a different understanding and should not cause anxiety among the patient or the physician who's treating them. Then there's a category of cysts which cannot be fitted into any of those that I told in the beginning, and they can be subjected to either invasive surveillance, that means you do an EUS and FNA and make a clear-cut diagnosis that gives reassurance to both patient as well as the doctor who's treating, or you can subject them to non-invasive surveillance at various periods of time. So European guidelines, I said, considers all pancreatic cystic neoplasms, but they depend on a multidisciplinary approach. What does it mean? It means that it includes a surgeon, a gastroenterologist, a radiologist, oncologist, and so on and so forth, who has a say in that patient. For IPMN, all the guidelines have slight variations. Let's see the European guidelines, which says that cysts which are more than 4 centimeters should be subjected to either surgery, whereas most other guidelines take 3 centimeters as a cutoff. The absolute indications for surgery is a solid mass within the IPMN, presence of a mural nodule, duct which is more than 10 millimeters, and presence of jaundice. And if you have a positive cytology, if you have obtained by EUS guided FNA. How do we survey these patients who have without any high risk of worrisome features? And you look at this, it's a complex table, but worth a read at leisure, because all this say that the cysts which are small in size, the cysts which are small in size need to have a longer interval of surveillance, whereas cysts which are larger in size, 2 centimeters or more, should have a shorter interval. This is a sum of all these various guidelines. It can vary from 6 months to 1 year, MRI versus CT or alternate, involving EUS in between. That's a little complicated, and I don't think it's worth discussing in this forum at this point in time. What are the indications of surgery in suspected serous cyst adenoma? Remember, I told in the beginning, these have less than 1% chance of risk. So all asymptomatic patients should be followed for a year. If there's no growth in size, they can be just left like that. But if this cyst, which can become very large in size and can cause pressure symptoms, or sometimes can cause obstruction to the bile duct or the pancreatic duct, then it may be worthwhile considering surgery, because there is a remote possibility of malignancy developing in them. In a large cyst, but a small cyst, 2 or 3 centimeters, classical appearance, one-time diagnosis, and you can reassure yourself and the patient, which would be quite good. ACG guidelines, I told earlier, they do not consider, they take all cysts except those who have genetic predominance. So how does one decide which cyst to do what? So balance has to be made. Cysts which have low risk of malignancy, and often they are detected frequently. Also, one should include the cost analysis of surveillance, which is often high. If you keep doing this cyst and evaluation every year for 5 years, or sometimes some guidelines say lifelong, then that has become very costly to the patient if he's paying from his pocket, or even from the insurance agencies who are feeding him, versus the benefit of a cancer prevention. This has not been proven. A very important point of cost benefit versus prevention of cancer. Also, there is no dedicated cost-effective analysis about surveillance of incidental pancreatic cyst. Having said that, you cannot subject all patients of doubtful cystic neoplasm who may be harboring a malignancy also for pancreatic surgery, because risks are also high there. Mortality rate of this incidental pancreatic cyst is about 2%, not very low, and morbidity is 30%, which is quite high. I'm sure most of you must have seen patients who had surgery come with a pancreatic leak or a fistula. Having said that, what imaging techniques should one use to characterize a pancreatic cyst? MRI or MRCP they would have a first imaging by which they come to you, which is often an ultrasound. And then how do you proceed further? I think MRI and MRCP is a test of choice, also recommended by the Radiology Society, because it's non-invasive, there's no radiation. It can be followed up repeatedly, and it accurately tells us whether a cyst is communicating with the pancreatic duct. Having said that, even pancreatic protocol CT, if it is done, is also quite good, and so is EUS. And they're excellent alternatives to each other. In fact, they also match in both sensitivity and specificity. Having said that, sometimes cysts are, in spite of the perfect imaging, will not be diagnosed on one method. And just like we do a second imaging in HCC or hepatocellular cancer, the same analogy is used here, where you do one more imaging. If you have an MRI which is not giving a clear-cut answer, you do a EUS or a CT to find that if two are matching together, then you can say, okay, this is the most likely diagnosis. Or you can follow with an EUS FNA. What is the accuracy of these imaging tests? The caution should be that when you use an imaging to diagnose a cyst or a concomitant malignancy, because they are not foolproof. Most imaging can give you an estimate about 60 to 70% of a diagnosis. So 1/3 of the diagnosis can be missed even in these best of the imagings. For example, the accuracy of MRI, MRCP in diagnosing a cyst is about 40 to 50%. And differentiating from a malignant from benign is also about 55 to 3/4. So not perfect. So both diagnosis and differentiating from malignancy, which is both these information are important. And that's why sometimes rely on the second imaging. And so does the accuracy of CT and EUS. So you cannot diagnose by one imaging perfectly. Okay, so having said that, we need to do further diagnosis to establish a kind of what we are dealing with. But what do we do, or when do we decide not to do any further imaging in a patient, or when to not survey a patient? When a patient is unfit for any surgery. So even if you diagnose a problem, you'll not be taking him for surgery. So why take the effort and cause both anxiety as well unnecessary investigation in these patients, irrespective of the cyst size. And you see here, all these guidelines have strong recommendation. These are experts who are talking about it, but the evidence is very poor. Cysts with very low risk of malignant transformation, example, serous cyst neoplasm, also do not require further treatment and evaluation. So patients who are unfit for surgery and cystic neoplasm of the serous variety need not have further evaluation. What is the role of EUS FNA and cyst fluid analysis? It should be considered if the diagnosis is unclear in the first imaging, or if it is likely to alter your management. Suppose you have decided, okay, I'll take up the surgery, but you do an EUS and find, okay, it's looking classical like a serous cyst adenoma missed by the previous imaging, then the whole scenario changes. More often than not, you can also do a cyst fluid analysis, and CA is the commonest tumor marker which is done. It helps in differentiating the mucinous variety, that is IPMN and MCN, from the other cysts. They usually have a higher value compared to the other type of cystic neoplasm. But the caveat is that very high value doesn't tell you that this patient has a high-grade dysplasia or a cancer harbored in that cystic neoplasm. So the value is not equal to the severity of the illness in a mucinous cystic neoplasm. What about cyst fluid cytology? It has very poor yield. The cellularity of the cyst fluid is very poor, and that's why only 1/3 of the diagnosis can be made through a cyst fluid analysis. However, you can find high-grade dysplasia, especially if you target the mural nodules or a solid component in a cystic neoplasms. Molecular markers are generally in a research protocol, and I leave it there only. The cutoff value that we use for CA is 192, and the pooled sensitivity of this is in 2/3. That means that if you have this value more than 192, the possibility of that lesion being a cystic of the mucinous variety is only 2 out of 3, but the specificity is quite high. And this has been shown in both systematic review and meta-analysis. Mind you, I repeat that the cyst fluid CA does not identify the presence of high-grade dysplasia or cancer in that lesion. Cytology, I told you, has a slow cellularity, about 1/3, and this has been also in IPMNs and MCNs, including the pooled sensitivity is quite poor in many larger series which combine together. So how do we improve the tissue acquisition? There are several devices enumerated here. Cytology brush, where a brush goes through a 19 gauge FNA needle and scrapes the wall of the cyst, and then this brush works like similar to a ERCP brush, but this was led to a lot of adverse events, including pancreatitis and bleeding, and hence it's kind of been withdrawn from the market. The new kid on the block is through the needle microbiopsy forceps, or the More forceps. The preliminary reports suggest it's very exciting. You pass this forceps, it's a micro forceps quite similar to the spy bite, which goes through a 19 gauge needle inside the cyst. Under US guidance, you go to the opposite wall and take a bite out of it. However, we need more studies to say that this is going to make a difference in management or for diagnosis. Cystoscopy is passing a spyglass through the cyst wall and inspecting the cyst from inside. It differentiates serous cyst neoplasm from others and also helps in differentiating IPMN from MCN. Some of the images I'll show you. This is a serous cyst adenoma on cystoscopy, a mucinous cyst adenoma, and these are IPMN with the fish egg appearance. This is how through the needle biopsy forceps looks like. And another new technology is a confocal laser endomicroscopy, which tells us the real-time histology of the cyst inside. And this probe also passes, a laser probe passes through the 19 gauge needle, and you can touch the opposite wall and get a real-time histology. The next part, which I'll discuss in next few slides, would be cyst ablation, which is considered in patients, since we know that the surgery is high risk, can be high risk, or can have morbidity. Why not do something which is less invasive and still ablate the cyst? And this is the premise by which US guided cyst ablation has been propagated. It obviates the need for surgery. And the two common methods is alcohol installation, which can be in combination with paclitaxel. And mind you, these method of treatment of the cyst neoplasm or local ablation has come from mainly two parts of the world, from Seoul and from US in few dedicated centers. We have them injecting alcohol, withdrawing it, re-injecting, and then finally leaving some paclitaxel in the end. The results are variable, although some centers show that the ultimate cyst resolution is 90% plus over a period of time. But overall, the variable results are 33 to 79%. Adverse event is seen in about 10%, which includes fever, pain, pancreatitis, and peritonitis, including venous thrombosis. RFA has also been tried, although in very small case series. So the debate of cyst ablation is, does cyst decrease in the cyst size after ablation, does it really eradicate the risk of high-grade dysplasia or cancer developing? Most recent studies from Korea say yes, but there are case reports that cancer has progressed, and this is an area which is of intense scrutiny world over. Also, if you do an ablation within an IPMN, IPMN, has a field effect, and people have a predisposition of a adenocarcinoma developing at separate areas. So just if you ablate the primary lesion, does not take away the need of surveillance. So surveillance has to be carried on because they are still predisposed to adenocarcinoma. So there is insufficient evidence to say that the cyst ablation should be continued. And if it is to be done, it should be done under research protocol. Let's come back again to cyst surveillance. So which of the cysts should be kept under surveillance? It should be in patients who are surgically fit, which means that the cyst is small. If it keeps becoming bigger in size and the patient remains surgically fit, then he can be considered for surgery later on, if not now. But if somebody is surgically unfit, there is no point continuing the surveillance. What is the benefit or survival benefit of this surveillance versus no surveillance? And there are no studies to prove that, because there is relatively low risk of malignancy or low chance of malignancy in all the patients who have this incidentally detected cyst. Even in surgical series who have undergone surgery for incidentally detected cyst, the presence of malignancy or high-grade dysplasia was found in less than 2/5. So that means in 3/5 of the patient, or 60% plus patients, you're doing surgery for unknown reasons, which carries higher risk, morbidity, and even remotely mortality. So one has to weigh the risk of surgery and their benefits. Because we also know there are inherent limitations of surveillance. Not everybody can keep coming every year, every 6 months for one imaging or the other. Also, it also depends on the site. If the cyst is located in the head, then the treatment is Whipple's, which carries higher morbidity and mortality, versus a cyst which is located in the tail, where the surgery is relatively easier. So which cysts require increased surveillance or referral to a multidisciplinary group for further? Or neoplasms. Do I have time, Malay, or I have finished it off? So any patient who has a recent onset worsening of diabetes, just like pancreatic cancers, chances are more. In these patients also, you should start considering that something is happening in them, or the change in size of this cyst. If you have a doubt, you can follow with an US FNA as suggested by some of the guidelines. American guidelines suggest that if the patients have symptoms, or the imaging has changed, or if there is a presence of high-grade dysplasia or malignancy on cytology. So these are the indications when you take them for a referral to a center or surgery to be considered. MRCP is the imaging of choice, I told you earlier, because of better contrast resolution, evaluation of main duct communications, presence of septae in the cyst, and even mural nodules can be picked up, and there is no radiation. EUS matches, but it is invasive comparatively to MRCP. It can be considered in patients who are can be subjected to MRI for a variety of reasons, claustrophobia, or if they have implants in them. It sometimes gives better resolution than a cross-sectional imaging, It has higher sensitivity for differentiating benign from malignant, and FNA is possible and by US. When do we stop cyst surveillance? It should be discontinued if the patient is no longer a surgical candidate, and if patient is beyond a certain age. This can be individualized and based on the overall fitness of the patient. The AGA says that the cyst surveillance should stop about 5 years if there's no change in the size and no appearance of the high-risk features. But however, there is insufficient evidence currently to support discontinuation after 5 years. In the end, I would like to conclude by saying that accurate characterization of pancreatic cyst is the key to management. Any high-risk features on imaging, one may consider EUS FNA or subject them to direct surgery. It varies from guidelines to guidelines. Surgical resection should be considered in patients who have high-risk features on imaging, or EUS which is suggestive on imaging or on FNA and the clinical setting. Surveillance is based on the type of the cyst that one is dealing with, the size of it in the beginning, and how it changes over a period of time, presence of main pancreatic duct dilation if present, and any other high-risk features like mural nodules and so on and so forth. Surgery, if considered, should be performed at high volume centers to optimize the outcomes in both terms of morbidity and mortality. Thank you very much for your kind attention.
Yeah, Dr. Malay, you are there?
You are was a fantastic talk, Sundeep. So the only thing is, I would like to ask, there are a lot of people, but how many surgeries, Sundeep, you do in a year for pancreatic cysts?
Well, that's a difficult question you're asking me. I don't have the data from the surgical team, but I would say at least 2 a month is what they would be doing. That's my rough guess, but accurate numbers, I think a surgeon from our team could tell.
The serous cyst adenoma is still just how many you would have operated?
Okay, that's a very interesting area that you have touched, Malay. I distinctly remember 2 patients in last 10 years who underwent surgery because of cyst, which was very suggestive of serous cyst adenoma on EUS, but they had features of a dilated pancreatic duct upstream to the lesion. And whenever a duct dilates upstream to a lesion, that's a feature of high risk. We learn it from our IPMN guidelines, 5 millimeter or more. But if there's a transition at the cyst level to a higher level, and both these patients who underwent surgery did not have any malignancy, but we got it done in these younger patients who are fit because of this fear of a duct which was dilated. And these were not a long-term follow-up. They were probably 6 months to 1 year of follow-up. The cyst did not change in size, but the caliber of the duct upstream appeared to have become a little wider than before.
One last question from myself before I hand over the mic to other moderators also. How many times have you been proved wrong in your EUS diagnosis by your surgical colleagues?
Quite often, Malay. I must admit that, and this happened more earlier in the earlier phase of my career, but now I am more diplomatic in my answering.
Seasoned.
So I still say that we will not be 100% right. I think I agree with the literature, although I've not objectively analyzed that 2/3 of the time we may be correct, but 1/3 of the time we may be wrong.
Okay. So Vikram, what is your take? You have some questions.
Yes, so I agree with Dr. Sundeep that yes, I was more often wrong previously, but then I think I was more often wrong because I was very categorical about what the cyst was. So I think one has to be humble and express uncertainty that there is a differential. A morphology can never be diagnostic. A cytology can be diagnostic in a small proportion, but a morphology can only narrow the differential unless it is a classical serous cyst adenoma. Having said that, to answer your first question, yes, I have made mistakes also. and at least 3 of my serous cyst adenomas have gone to surgery, but those were misclassifications from my side. So I could not classify properly a macrocystic serous cyst adenoma, mistook or misclassified them as mucinous cystic neoplasms, or was honest enough to say I could not classify them, and then they went to surgery. So we are more cautious when the cyst is in the head of the pancreas, when the implication of surgery is a Whipple's versus a distal pancreatectomy, when we are more liberal. So it is not only how certain we are, it is also how liberal we can be depending upon the location of the cyst and how good or bad the overall condition of the patient is, which dictates who goes for surgery.
Vikram, one more question probably you can answer where. Contrast, probably both of you can answer one by one. Contrast, does it make a difference in evaluation of cyst?
Yes, yes. Good question. Most of my patients now, I would use contrast ultrasound as a routine, and it does add information. I would like to see the enhancement of the septae. As Dr. Sundeep rightfully said, the normal parenchyma between branch duct cysts. So equitable enhancement compared to the normal pancreas in a branch duct, hyper enhancement in a serous cyst adenoma, mural nodules enhancement, and most often we get confused whether this is actually in practice a pseudocyst or a cystic tumor. So let us be honest, even with a good history examination, we often end up confusing a non-malignant or non-epithelial cyst from epithelial cyst, and that is where a enhancement of the wall or the septae sort of gives me confidence, enhancement mainly of the septae, that there is living tissue inside this cyst, and hence this is not a pseudocyst. So I use it almost as a routine now, contrast.
Sundeep, your take on the contrast?
I use it very less, and one, because it's not easily available, it's a little expensive and adds to the, but sometimes, especially in, I haven't used too often in cystic neoplasm, but I use it often for PNETs, where if they're doubtful other imaging and tissue diagnosis is not very obvious, because they enhance very well in the arterial phase and they become almost white.
Yes, so even
cystic neoplasm only we use it for when you have doubt of a mural nodule versus a mucin plug, because mural nodules enhance, whereas mucin plug will not enhance, and that will differentiate, and because that's a high risk feature which will be picked up by this.
Yes, so even in a cystic PNET, the wall will often enhance with a contrast, as rightfully said. But then I think that a contrast US in most of the cases would add little or more depending upon what you are looking at. So I am pretty liberal in using it now for a cystic pancreatic tumors.
So we take a balance of the opinion, because though Vikram says he categorically he would like to do contrast in almost all cases, and I would agree with him, because this is a very important decision. But there are two problems. Number one is the cost, which I don't think should be a problem, because this is a very important decision for that patient, and sending the patient to surgery is another problem. And the second problem is contrast is not routinely done in many countries, probably in America or in some country. Contrast enhanced ultrasound is not part of the routine yet. So this is, now Sandeep, one more question. Between a nodule, given a chance to do FNAC from a nodule or to tap fluid, would you take the FNAC of a nodule, mural nodule, or you would take fluid?
I will take a nodule first, because that's going to have a more concentrated amount of dysplastic cells, and having punctured through the fluid, I will take the fluid as well. So the first pass goes into the solid nodule, that tissue is aspirated out, and on the way out, you take out as much fluid as possible, which goes for cytology as well.
So first aspirate the fluid and then hit the nodule, or first the nodule, then hit the fluid?
First hit the nodule and then aspirate the fluid.
Vikram, your take?
Absolutely agree with Dr. Sundeep. If I hit a nodule, I've gone through the fluid. So if I aspirate first, I cannot identify exactly very often where the nodule has gone, and to differentiate it from the wall. So through the cyst, I hit the nodule, make a FNA, then a second pass goes in. I've already violated the cyst fluid. So I aspirate it and then aspirate the cyst to dryness. However, if the nodule is large and I can approach it tangentially without going through the fluid, and the nodule is large, I may just go for the nodule itself.
Vikram, positivity of nodule versus fluid?
Nodule is much more. Nodule is by definition the tumorous tissue. So in cyst, it is a hit and chance whether your cytospin will pick up how much the epithelial lining is denuded and how many epithelial malignant cells are floating in this cyst. So it's more of a hit and trial. A mural nodule by definition is at least a adenoma, if not an invasive carcinoma. So then you are in the tumor.
In fact, if I can add to that, the cytology yield of the fluid will actually increase after the FNA of the nodule because some of the cells will get dispersed into that fluid now.
You spill it.
Dr. Kaushal, would you like to add something or ask some more questions, please?
Yeah, so Sundeep, that was a very nice presentation. But for people like me or other community gastroenterologists who don't do EUS, so what would be your message? So if you have a pancreatic cyst, do you require EUS in all, or you can stop at a cross-sectional imaging? Or
That's a very good question.
We refer all patients for EUS?
No, not all patients. So if we have the diagnosis established on the first imaging that we get, and if it's MRI and it shows that the cyst is communicating with the main pancreatic duct, that itself diagnoses it as a side branch IPMN or a mixed variety of an IPMN. Or if the CT, which is more commonly done in India, shows that the calcification of the wall of a cyst, that suggests a mucinous cystic neoplasm, diagnosis gets established, and then we can decide about if surgeons take it directly or if they want further tissue diagnosis, then we take EUS into picture. And the third category is when the diagnosis is not very clear cut. You have a cystic neoplasm and the debate going on between one versus the other, then EUS comes into picture. So indeterminate cyst, EUS adds value. Those which are diagnosed by the first imaging, be it CT or MRI, we can stop there and take a call based on what we have diagnosed.
Thank you.
Malay, can I make a comment?
Yeah, please, please.
Hi, Sundeep, excellent talk. Good discussion. One point about serous cyst adenoma, if they are symptomatic, then we have operated on them. And very occasionally they are symptomatic for one reason or another. Second point is that they also grow. Serous cyst adenomas grow. Growth is concerning sometimes, obviously, but we have re-FNA'd them, but usually the diagnostic yield is very poor in that. But other than that, we stay away from surgery in that group. Malay, you mentioned we are not using contrast EUS or other types of enhanced EUS imaging in America. It's just not caught on. I think there's an additional cost to the EUS apparatus with that. But particularly in the cystic realm, I think solid cystic lesions might benefit from it. Even in the solid lesions, the contrast enhanced imaging is debatable, as Sundeep rightly pointed out. So it hasn't taken on much in the US. And finally, in terms of which patient to go to surgery, I think that's a complex discussion. We have increasingly involved the patient in this shared decision-making model where the cyst characteristics, the serum values for labs, the timeline of the growth of the lesion, all of those factors, the surgical fitness, very appropriately pointed out. And we then finally bring in the patient into the discussion. And most of the times for indeterminate cysts or where the risk is high and the benefit may be low, shared decision-making with the patient is a very valuable tool in this population. Thank you.
I would like to make two comments. As Dr. Sundeep said that mistakes are many and they are more in the initial phase of the learning curve. And if there are so many mistakes with the experts like Sundeep and Vikram, I would say that one should be very cautious in, first of all, in diagnosing the pancreatic cyst. I would like to share experience of two patients in which the cyst was diagnosed as a pseudocyst and a surgeon attempted a cystogastrostomy and it was a cystic tumor. So these things, they do happen and you have to be very careful, number one. And number two, a small thing I have seen that sometimes the lipomas, intrapancreatic lipomas, though they are very rare, I have seen two. And one of them had a CT appearance of a kind of a cyst because it appeared almost black. So there was a lot of confusion initially, and though later on it was cleared. But what about your experience regarding a lipoma, Dr. Sundeep?
So that is great experience, Dinesh. And Rinkesh, would you like to add anything more to the discussion?
Very nice talk, Dr. Sundeep. I will just ask about the role of EUS elastography of any type of cyst you will recommend, role of elastography. Though it's not required, I know, but any type of cyst.
I think EUS elastography is still a technology which has to find its place. It's available, but what's the benefit of using this? We need much more studies on that. They're more often used in a solid and a hard lesions, that is solid neoplasms versus cystic neoplasms. I think that's the. I think it's not much value at the moment in the cystic neoplasm per se. Dinesh, to answer your question, I haven't seen a lipoma as yet. You have been lucky enough to see in the pancreas.
Maybe
I'm aware that this is a dilemma which occurs in patients who have a black lesion on a CT and on pancreatic protocol CT, which you don't see a cyst on the EUS, and then you get doubtful what was that.
If there are no more questions, may I take this opportunity to thank Dr. Sundeep for his elaborative talk, one of the excellent presentations I've ever heard. Thank you, Male, for moderating the session very well, and I'm also thankful to all the panel members for having a good discussion on this evolving field of management of pancreatic pseudocyst. And we can appreciate that even if amongst the experts, we are not able to confidently diagnose, look at what happens with us as the beginners. This is the learning phase, and I'm thankful to Dr. Sundeep, panel members, and Malik for taking it forward. Thank you so much.